This podcast series is made possible thanks to the generous support of the Patient Care Foundation. The Patient Care Foundation supports medical students in need through scholarships. Each year, the Patient Care Foundation changes lives forever by giving deserving medical students facing incredible odds funds to continue their education, resources as they deal with food, housing, and transportation insecurities in the wake of COVID-19. To learn how you can make a difference for a young medical student, visit ladocs.org. Click Advocacy and Patient Care Foundation. Welcome to this edition of Clear as Mud, the podcast dedicated to bringing clarity to medicine. I'm your host for this episode, Gustavo Friedrichsen. Recently, Governor Gavin Newsom signed Assembly Bill 890, the so-called Nurse Practitioner Scope of Practice Bill. Among other things, the bill would authorize a nurse practitioner who meets certain education, experience, and certification requirements to perform as a physician does. This bill is so important, we're dedicating the entire 10-minute broadcast to share what's next for doctors. Data has shown that physician-based care is the model that ensures the greatest patient safety and the highest quality care for all Californians, regardless of income. Joining us today is Francisco Silva, General Counsel at the California Medical Association, who has graciously accepted our invitation to discuss the latest on AB 890, what every doctor needs to know, and to counter misinformation. So Francisco, welcome to Clear as Mud.
Good morning. Great to see you, Gustavo.
Great to see you too. Can you briefly share what the sponsors of AB 890, namely Assemblyman Jim Wood, what were they hoping to achieve with this bill?
Well, all I can tell you is from what we heard and what we saw in the narrative, the goal was to try to ensure that nurse practitioners had the ability to practice in areas that were underserved. That was what they stated. I don't think necessarily that is the scope of the bill. It is much broader than that. It potentially creates these two new categories of nurse practitioners that can practice, frankly, anywhere. The bill doesn't guarantee that they're going to serve in underserved areas, but it does create these two new MP categories.
These proponents have said that the legislation will help increase access to care and ease supervision of nurse practitioners. First of all, is that true? And second of all, what do you think is actually true and factual?
Well, I think what's really important to understand is also what the bill didn't do, because there's a lot of confusion around this bill and what it means for medicine, what it means for physicians and how they practice with their nurse practitioners. Under the current law and current practice, physicians practice with NPs all the time, right? And what the bill didn't do, it didn't touch that or address that at all. So the current procedures, current standards, and the way physicians currently practice with NPs and the way nurse practitioners currently practice, the bill didn't touch. It didn't address that at all. So I think that's really important because the primary question we're getting from doctors and members of the public is, what does that mean? Are nurse practitioners going to practice differently now? Well, the answer is no, with respect to current nurse practitioners. What the bill did do is it created the pathway for two new categories of nurse practitioners. We refer to 103s and 104s only because those are the sections of the Business and Professions Code that created these new avenues. And it tells the Board of Registered Nursing to create regulations that allow these new category of NPs, if they meet certain requirements, if they take a certain test, if a test is required, to then practice without standardized procedures. And what does that mean? Standardized procedures under current law, nurse practitioners have a lot of flexibility in terms of what they can do. They do it under standardized procedures with the physician. So whichever physician they practice with or medical group they practice with, there's an understanding based on their training and education of the nurse practitioners of what type of services they can provide. And what this bill does for these new categories is it removes those standardized procedures. It would effectively allow these nurse practitioners to practice without that if they meet the additional requirements that we don't know about yet.
It just seems like, this is going to change the dynamic within the clinical setting as well, right? Do you see some repercussions, some consequences in terms of the overall culture or dynamics within a practice setting when the nurse practitioners feel empowered or have more ability or more leeway, and the doctor seeing his or her abilities and skill sets being diminished to a certain degree? Is that a fair statement, or what? How would you assess that?
Well, I think you're touching on where I anticipate the potential issues are going to arise, which is in the practice setting. What does it mean to have a nurse practitioner that, under the current arrangement, is very collaborative, but now you don't have those protocols, those procedures that kind of dictated the relationship between the two. So I think there's a lot of questions there. What does that mean? Are they truly independent? I think the bill's not clear on that front. There's pieces of the bill that still require collaboration, definitely, between the physician, the health facility, and the health facility situation, and these NPs. And I think the other thing that's really important to highlight is that the bill doesn't require that they be hired. So a health facility or a medical group, for instance, can choose to still practice under the standardized procedure model and say, just like a medical group right now can decide, I'd rather work with a physician assistant than an NP. It's an economic choice based on what they think is most advantageous. So a medical group or health facility can still decide, I prefer the model under a standardized procedures. Or it might be the opposite, right? Where they may say this new model is a better model for whatever reason. So I think that's the way it's going to play out. And I think that's why you'll see that.
So I don't want to dwell too much on the journey of the bill and the process regarding the bill, but if you can just touch on for a second how COVID-19 changed everything relative to not just the understanding process on behalf of the assembly, but just the timing and the actual result, and how the pandemic actually affected this process. But just if you can touch on that just briefly for the audience.
Yeah, just briefly. What I heard from our lobbying team, and what I've heard from other lobbyists. I live in Sacramento, and what's changed during this COVID environment is they're used to having a dialogue with legislators in person, where you have a back and forth and you're able to identify issues and say, just like the issues I've identified today, like, well, that's not clear and that's not clear and that's vague. And a lot of times that slows the process down, and it allows you to like fine tune that, or a bill like this, maybe it would be held to figure out the details. But under this environment, you were left to have that conversation on the phone. If you were lucky, via Zoom. And for hearings, there wasn't that exchange that folks are used to. So there's a feeling in the Capitol that part of the process kind of broke down. So bills that normally wouldn't get through the legislature got through the legislature because of that dynamic and missing that dialogue.
So what do you think? I know you talked about this before. What's the short-term and long-term sort of strategy from a CMA perspective relative to either the regulatory process or other opportunities?
Well, ultimately, CMA is supportive of making sure we have access to care and patients have access to care in underserved areas. So we're going to lean into and continue to work on those type of projects. As you know, we have a 501c3, Physicians for Healthy California nonprofit, that has a loan repayment program to attract physicians to underserved communities. And we also have the residency program that we administer that's focused on getting residents to those communities that typically don't get physicians, because all the studies show that's where they do their residency is where they stay. So I think that's part of the puzzle, right? The workforce, making sure patients have access to care. With respect to this new category of nurse practitioners, I think we're going to focus on the principle of making sure that the education and training matches the scope of the services they provide. So patients have the right to get high quality care. So for instance, in this bill, you can read the bill to say that these new category MPs can administer anesthesia, but you shouldn't let them administer anesthesia unless we are absolutely certain that they have the training and education to do that. And you do have a category of nurse anesthetists that specifically train for that. But these MPs, the statute doesn't address that, but makes it possible. So I think for us, it's going to be working with the specialty associations, working with our county medical societies through the regulatory process to make sure that the education, the training has to match.
And I'm assuming as well that as time goes on, CMA will be putting out either a toolkit or just relevant information and updates on what's going on regulatory-wise, communications-wise. I'm sure that's going to be coming out of CMA, as you guys always do on a regular basis.
Yeah, absolutely. We have a fact sheet now that's available on our website, whether you're a member or not a member. We're publishing a fact sheet this week that's more in depth in terms of the legal analysis. And that fact sheet, it's FAQ. It's going to be amended over time. So every week, if we find something new, absolutely. And then the other piece is we're going to engage our members and physicians in the process, because I think it's important for the nursing board and the other regulators who are involved, like the medical board, to hear from physicians and how it impacts the practice of medicine, and what's the optimal way to provide high quality care to patients.
Well, Francisco, listen, I know you're super busy. I want to thank you for being our third guest on Clear as Mud. And on behalf of our 7,000 members, our board of directors, our executive committee, I just want to thank you. We all want to thank you for the work that you do on behalf of physicians and patients throughout your career. So we wish you well going forward. So thanks again for being on Clear as Mud.
Thank you. And hopefully I was a little clearer than mud.
You were.
Thanks, Gustavo.
Thanks to Francisco Silva, General Counsel at CMA, for joining us for this episode of Clear as Mud. We hope we shed some light on how AB 890 is just bad legislation and what steps are being taken to mitigate consequences for physicians and patients alike. To learn more, download expanded commentary or tap into resources to help you thrive now and in the future as well at ladocs.org. Again, to learn more, download expanded commentary to help you thrive in your practice. Visit ladocs.org. Thanks again. Many thanks to our sponsor, the Patient Care Foundation, for their generosity, and our production team. Thanks for listening to Clear as Mud. Be safe.